Welcome to ABC Tutorial. Today we'll talk about systemic hypertension. Hypertension is a chronic disorder characterized by persistently elevated blood pressure. Blood pressure measures the force the blood exerts on the walls of the arteries as the heart pumps it throughout the body. Blood pressure is expressed as two values, systolic and diastolic blood pressure. The systolic blood pressure, which is higher, represents the force during heart contractions, that is, in systole, while the diastolic pressure, which is the lower value, indicates the force when the heart relaxes, in diastole. Normal blood pressure typically falls within the range of 90-60 mmHg to 120-80 mmHg. Hypertension is diagnosed when blood pressure consistently exceeds 130-80 mmHg, although classification may vary based on medical guidelines. Systemic hypertension is primarily classified into two categories, primary and secondary hypertension. Primary hypertension is the more common form and is often called essential hypertension. It has no apparent cause. It usually results from a combination of genetic, lifestyle, and environmental factors. Secondary hypertension is caused by underlying medical conditions such as kidney disease, hormonal disorders, or certain medications. This form of hypertension is common in the pediatric population. Treating the underlying cause can often manage this type of hypertension. Hypertension is a major cause of premature death worldwide. An estimated 1.28 billion adults worldwide have hypertension, with about 2/3 living in low and middle-income countries. An estimated 45% of adults with hypertension are unaware that they have the condition. Only about 20% of adults with hypertension have it under control. One of the global targets for non-communicable disease is to reduce the prevalence of hypertension by 33% between 2010 and 2030. The pathophysiology of hypertension is complex and not completely understood. Blood pressure can fundamentally be viewed as a function of cardiac output and systemic vascular resistance. Cardiac output depends on heart rate and stroke volume. Stroke volume in turn depends on myocontractility, preload and afterload. Systemic vascular resistance is dependent on vasodilation and vasoconstriction. Thus, any factor that affects any of these determinants could in effect lead to elevated blood pressure. The exact cause of primary or essential hypertension remains elusive, but several risk factors contribute to its development. Modifiable risk factors include unhealthy diets such as excessive salt consumption, a diet high in saturated fats and low intake of fruits and vegetables, sedentary lifestyle, alcohol consumption, smoking, and being overweight or obese. Non-modifiable risk factors include a family history of hypertension, advanced age, and coexisting diseases such as diabetes mellitus, chronic kidney disease. Secondary hypertension results from specific medical disorders, some of which include renal disease such as chronic kidney disease and renal artery stenosis, vascular causes such as coarctation of aorta and collagen vascular disease, hormonal disorders such as Cushing syndrome and congenital adrenal hyperplasia, medications including oral contraceptives, corticosteroids, decongestants, and illicit drugs such as cocaine and amphetamine, thyroid disorders including hypothyroidism and hyperthyroidism, pheochromocytoma, which is a rare tumor of the adrenal gland that can lead to excess adrenaline production and cause high blood pressure. Hypertension is typically diagnosed based on multiple blood pressure readings taken over several visits. A diagnosis of high blood pressure is usually based on the average of 2 or more readings taken on separate occasions. Based on the blood pressure reading, the patient is classified based on various guidelines available. Categories defined by the American Heart Association (AHA) include normal blood pressure, when the systolic blood pressure is less than 120 mmHg and diastolic blood pressure is less than 80 mmHg. Elevated blood pressure, when the systolic blood pressure is between 120 to 129 mmHg and the diastolic blood pressure is less than 80 mmHg. Stage 1 hypertension, when the systolic blood pressure is between 130 to 139 mmHg and or diastolic blood pressure of 80 to 89 mmHg. Stage 2 hypertension, when the systolic blood pressure is greater than or equal to 140 mmHg and or a diastolic blood pressure greater than or equal to 90 mmHg. While the JNC7 or 7th report of the Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure classified blood pressure into the following categories: normal blood pressure, when the systolic blood pressure is less than 120 mmHg and the diastolic blood pressure is less than 80 mmHg. Pre-hypertension, when the systolic blood pressure is between 120 to 139 mm mercury, and or a diastolic blood pressure between 80 to 89 mm mercury. Stage 1 hypertension, when the systolic blood pressure is between 140 to 159 mm mercury, and or a diastolic blood pressure of between 90 to 99 mm mercury. In stage 2 hypertension, systolic blood pressure of at least 160 mm mercury, and or a diastolic blood pressure of at least 100 mm mercury. Further testing in diagnosis and evaluation of hypertension can be used to identify potential secondary causes. Initial laboratory tests may include urinalysis, fasting blood glucose, serum electrolyte, serum creatinine, and fasting lipid profile. Other studies may be obtained on the basis of clinical findings or if there is any evidence of target organ disease, such as complete blood count, chest radiograph, electrocardiography, and echocardiography. Hypertension is often called the silent killer because it typically presents with no overt symptoms. However, long-term uncontrolled hypertension can lead to serious complications. Clinical features may include headaches, blurry of vision, insomnia, palpitations, dizziness, shortness of breath, and chest pain. Untreated hypertension can lead to severe complications like heart failure, stroke, kidney disease or renal failure, peripheral artery disease, and vision loss. The management of hypertension often include lifestyle modifications and medications. Lifestyle modifications include dietary changes, adopting the DASH diet, limiting salt intake, and potassium-rich foods. The DASH or dietary approach to stopping hypertension eating plan encompasses a diet rich in fruits, vegetables, and low-fat dairy products, and may lower blood pressure by 8 to 14 mm mercury. The American Heart Association recommends that the average daily consumption of sodium chloride should not exceed 6 grams, and this may lower blood pressure by 2 to 8 mm mercury. Other lifestyle modifications include regular exercise. Weight management, as weight reduction may lower blood pressure by 5 to 20 mm mercury per 10 kg weight loss. Stress reduction, limiting alcohol, and quitting smoking. If lifestyle changes are insufficient, healthcare providers may prescribe various hypertensive medications. These drugs are generally said to be the ABCD drugs of hypertension, which include angiotensin-converting enzyme inhibitors, also known as AC inhibitors such as lisinopril and ramipril. They block the conversion of angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor. Side effects include dry cough, angioedema, and renal failure. Angiotensin 2 receptor blockers, ARBs, such as losartan and telmisartan, they block the effect of angiotensin 2 at the receptor level. Side effects include vertigo, urticaria, and pruritus. Beta blockers such as atenolol and labetalol, they reduce the heart rate and cardiac output. Side effects include bronchospasms and impotence. Calcium channel blockers such as amlodipine and nifedipine, they prevent calcium from entering the cardiac myocytes and vascular smooth muscle cells, leading to reduced cardiac contractility and vasodilation. Side effects include gum hyperplasia and angioedema. Diuretics, including thiazide diuretics such as hydrochlorothiazide and the potassium-sparing diuretics spironolactone. Side effects of hydrochlorothiazide include hypokalemia and impotence. Other drugs that could be used in treatment of hypertension include alpha-adrenergic receptor blockers such as prazosin. This drug reduces the artery's resistance, relaxing the smooth muscle tone of the vascular walls. Side effects include hypotension, dizziness, and tachycardia. Centrally acting drugs such as methyldopa. These drugs reduce blood pressure by decreasing the activity of the sympathetic portion of the autonomic nervous system. Side effects include dizziness, dry mouth, and headache. Vasodilators such as hydralazine and minoxidil. Side effects of hydralazine include headaches and palpitations, while minoxidil causes excessive hair growth. According to the JNC8 guidelines in the general population, in adults aged 60 years and above, pharmacologic treatment should be initiated when the blood pressure is at least 150-90 mm mercury. However, in younger adults less than 60 years of age, the blood pressure cutoff for initiating pharmacologic treatment is 140-90 mm mercury. In patients with hypertension and diabetes, pharmacologic treatment should be initiated when the blood pressure is 140-90 mm mercury, regardless of age. Initial antihypertensive treatment should include a thiazide diuretic, calcium channel blocker, AC inhibitor or ARBs in the general non-black population. While in blacks, the initial antihypertensive treatment should include a thiazide diuretic or calcium channel blocker. If the target blood pressure is not reached within 1 month after initiating therapy, the dosage of the initial medication should be increased or a second medication should be added. A third drug should be added if necessary. However, if the target blood pressure cannot be achieved using only the drug classes listed above, antihypertensive from other classes, such as beta blockers, should be used. Adults with CKD and hypertension should receive an ACE inhibitor or ARBs as initial or add-on therapy.